Hi, everyone. Thank you so much for joining today. My name's Janine. I work for Long Beach Public Library. We're really happy to welcome you to the 2020 Active Living Series sponsored by Assemblywoman Melissa Miller, the Katz Institute for Women's Health and Northwell Health. This is a 4-week program for Long Beach Library, and it's happening every Tuesday at 2:30 for the next few weeks on Zoom. So please feel free to join next week, too. Today's presentation, we're going to learn about managing chronic pain with Dr. Madeline Gittleman. She's an attending psychologist at Cushing Neuroscience Institute with Northwell Health, and we're so grateful she's here to share her expertise.
Well, thanks so much for having me. I think this is a great series. I've seen what some of the other topics are. They seem really interesting. I'm hoping I could join in for some of the future ones. So thanks again for having me. Today I'm going to talk about managing life with chronic pain, which is no easy task. And we'll be referring to this metaphor of reclaiming the driver's seat throughout the presentation. Let me just see how I move forward. There we go. Okay, so we'll talk a little bit about pain, why it's so difficult to live with, why it's even something that causes distress in clinicians and the doctors that you might be seeing to treat this pain, and why it certainly creates a whole realm of stressors for you and your families. And then we'll talk about different strategies that are evidence-based for helping you live with chronic pain and enhance your quality of life, even if pain is going to be a part of it. And then we'll leave time, as Janine had said, at the end of it for questions. So for any of you who are currently living with chronic pain, you might identify with this cartoon. I found this, and I would say more than half of my patients are living with chronic pain right now, and I think they all feel like this cartoon captures what their experience is, which is not only one of a physical problem, but that living with pain that's persisted beyond 3 months, which is the current definition of chronic pain. For some of my patients, it's lasted for 20 years. It also creates a lot of emotional, cognitive, social distress. It ends up affecting all areas of your life, and it leaves people with feelings like this cartoon captures. Why does it still hurt? Am I imagining this? I'm useless. They should be able to cure me. How come nobody's helped me yet? And so it creates this kind of ball of helplessness on top of the pain itself. Why is pain something that causes so much distress? Well, we know one of the things is that pain is entirely subjective, right? At this point, we don't have an x-ray that tells you how much pain you're in. We don't have an MRI that can tell you where your pain is and exactly what the quality of it is, right? We know that all we have is the person's subjective experience, and it's not visible to the outside world. And so it's hard for the person because it's hard for them to experience any validation from those around them because the pain is invisible. It's hard for them to feel like it is real and it is an entity that is just as serious as, let's say, a broken arm or a broken bone or a mass. And it's hard for physicians because of that same reason. It's not something that is tangible, that they can see and know exactly how to target it. Another reason is that these two quotes, so pain is not a reliable indicator of tissue damage, and tissue damage is not a reliable indicator of pain. You could have two patients who come into an emergency room with the exact same complaints. Excruciating pain in their back, radiating down to their left leg. Exact same report. They're rating the pain at a 10 out of 10. Their presentation, they're sweating, they're grimacing, they're limping. Their presentations are identical. We MRI those two patients, and the results are drastically different, right? And then we could have two MRIs that are the exact same to the T. All of the anatomy is the exact same. One patient is completely disabled and unable to function in the world, and the other person is highly functional, engaged in their life in many different ways, engaged in multiple roles. So it tells you that pain is far from straightforward, and the tests that we have and the reports that we have also don't always make it such a straightforward experience. So here we go, just to introduce this metaphor that I use a lot in my treatment of patients with chronic pain that I think also captures the experience of what it's like to live with chronic pain. And I'll credit a former colleague of mine. Her name was Alessandra Strada, and she was the one who came up with this. And what she said is pain is like having an unwanted passenger in your car. She said it's as if you were driving along the road of life, making whatever turns you want, going whatever speed you want, traveling wherever you wanted to go. You decide one day to just pull over at a rest stop. And you get out, you're stretching your legs, but when you get back in your car, there's a random person sitting in your passenger seat. First, you start wondering, where did this person come from? They must be confused. They must be in the wrong car. And you say, excuse me, this is my car. You're in the wrong place. And they say, nope, I'm in the right place and I'm here to stay. And despite all of your efforts to get that person out of that car, they are there for the rest of the trip. You could imagine what you might be feeling. And I think it very closely mimics the experience of a person who develops pain. The first reaction is disbelief. And then it's the endless fight to get rid of it, right? We know that patients, when they first develop chronic pain, they don't know it's chronic. They just think it's pain like the other acute pain that they've had in their life, which we'll touch on a little bit later. And so they're just trying to get rid of it. It might mean going to multiple doctors, doing a lot of research, having a lot of consultations, doing x-rays, doing various things. They might even have procedures, all with the hopes of getting rid of it. But all going back to that passenger still being in the car, the pain still being in there. Why I also like this metaphor is it sets up the presentation, and also in therapy, it sets up the treatment really well, because what I always say with patients with chronic pain, I wish I had the magic pill. I wish I had the answer that just makes the pain go away. At this point, I don't have that, and I don't think anybody does. But it is feasible to help you gain control of the wheel and get that passenger to either be in the back seat or the trunk of the car, right? It is possible to learn how to reclaim some control of your life, even with chronic pain. And that's what we're going to talk about. The strategies that I'm going to talk about are really intended to help a person improve their quality of life, improve their mood, improve their relationships, even though pain is still going to be a part of their lives. So here's another picture that I think speaks to what can happen when you are living with chronic pain and where it can go if you develop some of these strategies. So we know when a person lives with chronic pain, as the first slide showed, it not only affects them physically, where the pain site is, but if they stop doing things, they stop exercising, they stop going out, we know that it could create atrophy in the rest of their body, so they become physically even weaker. They might also withdraw themselves from social activities, so now they're becoming a bit more isolated. That in turn might affect their mood. They might become much more depressed, much more anxious, and then they end up feeling this loss of identity. They're no longer working, perhaps they're no longer socializing, their mood has changed significantly, they're doing far less. If they had formerly been incredibly active and they no longer are, now they feel like they've even lost their identity. And so often when I am referred patients with chronic pain, they're at this kind of bottom of this downward spiral. And what I say our goal is to stop this spiral and then help them gradually work their way back up through educating themselves about pain, getting back into some social activity, even if it means adjusting the type of activity, learning how to engage in things with skills like pacing, doing things gradually, slowly, listening to your body, but also knowing how to set goals and push yourself a little bit, getting stable again emotionally, getting less depressed, getting less anxious, and now having way more emotional and physical reserves to cope with that pain. So here, how do we build the toolkit? Well, for those of you who are living with chronic pain, you have probably been introduced to a number of these. We know that aside from the strategies that I'm going to talk about, which are more self-management strategies, we know that there are medications that can be used to treat pain. And what's typically talked about and has gotten a lot of negative press is opiates. Those can be incredibly effective in reducing pain, but we also know that they come at a cost and can be very problematic in terms of addiction. I always like to say, sorry about the phone ringing, I'm going to try to turn it down. I always like to say, I think that we've gone from a place that this opiates is one of those things with the pendulum. So we had been in a time where opiates were viewed to kind of be the panacea. They were viewed to be wonderful, not very problematic. Doctors were prescribing them pretty widely without question, right? And of course, we saw the fallback of that and all the problems that ensued from that. Unfortunately, though, I think the pendulum has now swung in the opposite direction where we've kind of demonized opiates and even to some extent the people who use them. And I think that there are ways to use opiates safely, to prescribe opiates safely. There are more and more protocols that are being developed. And so I do think that it's an option, but there are other options. We're seeing more and more development of non-opiate medication that can be incredibly helpful. There's a number of interventions, surgical interventions, injections, we know for certain types of pain. There's also a newer world of what's called neuromodulation, which is things like spinal cord stimulators or various other stimulators that can be placed on certain parts of the body that have been showing to be somewhat effective in reducing pain. We're going to see a lot more of that. They're calling it electroceuticals, so using kind of electric stimulation to reduce pain, and we're going to start seeing a lot of that. There's the different types of therapies, physical therapy, occupational therapy, psychotherapy, coming to somebody like me and doing it more formally as opposed to just doing it on your own. And then we know there are these complementary alternative treatments like yoga, Reiki, Tai Chi, which I think one of the presentations is going to be done for the library on Tai Chi, massage, aromatherapy, a number of interventions like that. I'm going to focus on what we call behavioral approaches to managing pain. One concept that I think is important to just kind of understand when thinking about using the behavioral approaches is this concept of locus control and kind of how we understand ourselves in relationship to our experiences. And for this talk, how we understand ourselves in relation to our experience of the pain and of various strategies we can use to help our pain. Patients with an external locus of control view their behavior and their experiences as all focusing outside. So they often feel victimized by the pain and feel like they have very little ability to control their experience of the pain. People might have the experience of, I didn't bring this pain on, I'm not going to be able to resolve it. And so patients who have that mentality might kind of endlessly go to doctors with the hope that they will be fixed or cured. Unfortunately, with chronic pain, what we know is that having that mental set is not going to be incredibly helpful because we haven't gotten to that point of having a cure yet. So what we want to try to do is move people to more of an internal locus of control, which is a position of recognizing that they have the capacity to do things to impact their experience of the pain. They might not be able to eliminate their pain, but they can do things to improve or adjust their experience of the pain. And in the next slide, this is something I always start with. This is a perfect way of moving a person or moving you from that external place to the internal place. A lot of time when a person has pain, they're kind of focused on, how did I get this pain? What's the cause of this? What can the doctors do to help me? And we want to move them to these second questions, which instead is, how do I manage the pain? What factors influence the pain? And what can I do? And hopefully I'll give you some of the things that you can do. So one of the first strategies for managing life with chronic pain is to understand it and to educate yourself and to educate others around you. One of the biggest complaints I get from my patients is that their loved ones do not get what they're going through. They don't understand how awful the pain is. I've had plenty of patients say, if I get up and get dressed and do my hair, my family thinks everything's fine. And because my pain is invisible, they don't acknowledge that every day is a struggle because I'm living with this and fighting this. So sometimes if you have the language to kind of explain what it's like to live with chronic pain, it can be incredibly helpful. And I think this metaphor can help. With acute pain, we know that it is adaptive. Humans were built to have acute pain, right? And the classic model of how acute pain is adaptive is you put your hand on the stove, it creates pain, sends the message to your brain, right? Ouch, this hurts. And you take your hand off of it, right? The pain lingers just long enough so that you can remove your hand from the stove, and perhaps long enough so that you could treat it. You might put ice on. You might even find that you have to be cautious for a couple of days if a blister forms, right? So it allows you to put creams on and treat it, but then the pain resolves, right? With chronic pain, it is not adaptive. What it is like is a faulty alarm. So this is a bedroom alarm clock. It was supposed to be a fire alarm, but if you think of the fire alarm in your home, right, and you imagine that one day your fire alarm just goes off and fire department comes and they look around your house, they look around, they say, well, there's no fire, there's no smoke. I think the alarm just for some reason must have had some kind of issue with it, but everything's okay, we're gonna get going. Alarm goes off for a little bit, fire department leaves. Just as they're pulling out, alarm starts going off again. Fire department comes back. They look all around, sorry, ma'am, we don't know what's going on, but there's no problem. At this point now, the alarm doesn't go off. It continues to go. They try to take the batteries out. They try to play with different things. And at a certain point, they look at you and they just say, listen, we're so sorry. There's no fire. Everything's okay, but this alarm is going to continue to go off. We can't figure out how to turn it off. And you imagine, I think everybody's had the experience of how piercing a fire alarm can be, what it would be like to have that alarm going, going, going. Maybe some days it gets a little muffled. Some days the tone changes just a bit so that it maybe gets a little bit easier to deal with. Some days it maybe gets real quiet, but it never stops. If you all experience chronic pain, you know that that's a lot like what it is like to live with chronic pain. Another way to educate yourself, I'm so sorry this got flipped around, but um, a lot of times when you live with chronic pain, the last thing you want to do is to think about it. You probably have developed a good way of distracting yourself from it, and that's a great coping mechanism, but it's not the only coping mechanism. And sometimes delving into your pain can be incredibly helpful because you can learn a lot from your pain. So for instance, if you're a chronic headache sufferer, right, you can do what we call diary or journal your pain. Jot down when you're experiencing headache, what you were doing immediately prior to that, how you treated it, and what the effect of that treatment was. And what it will do over time is give you a sense of, are there certain things that tend to be triggering, which maybe you weren't aware of? Are there some things that tend to be more helpful than others? And so you end up kind of getting more acquainted with your pain, and therefore you can develop a little bit more control over that pain. Not complete control. All of my headache sufferers have wonderful journals and have a real good sense of their triggers and do a lot to either avoid those triggers or to engage in the things that they know help, and yet they still might have breakthrough headaches or a random headache that seems to be untriggered. But it still increases that sense of control, which can be incredibly helpful for our psyche when living with chronic pain. The other point I always like to make is we know that with the internet, research is at our fingertips. You know, the information about various sources of pain, various treatments for pain is at all of our fingertips. And there's something wonderful about that, but we also know that there can be something that can be damaging about that. And so I always say, doing research in moderation. And there's no way to know definitively or to tell you what that looks like because it's very individual. I have one patient who spends hours, spends about from 9 p.m. to 3 a.m. on her computer researching her pain condition and various things. And so we've had to limit it to about 2 hours spread throughout the day. 2 hours for another person, though, might be exponentially way too much and create way more anxiety than benefit. So what I always say is, really check in with yourself. When you're doing research, there's always that point at which you kind of cross over from getting some valuable information to entering into that place where it becomes kind of ruminative and more anxiety provoking than helpful. So you want to really be paying attention to that. Of course, also you want to be developing a good relationship with any clinicians that you're working on your pain with, anybody who is treating your pain with you. You want to develop a nice rapport with them because of that complex nature of pain. Treating pain has to inevitably be collaborative. They're basing their treatment on your feedback, and you're basing kind of what you're saying on the information they give you. So it has to be this collaborative relationship. Another hugely important thing in living with chronic pain is beginning to set goals for yourself again. When we when you saw that slide with that spiral, that downward spiral, one of the things that tends to happen is a decrease in activity, a decrease in socialization, kind of this withdrawal from life. I've had so many patients say that it's like my life shrunk, right? And so the way to get back some of life, and it might happen incredibly slowly, is to commit to setting goals for yourself again. And a lot of times when you live with chronic pain, it feels impossible. I've had so many people say to me, live a day in my shoes and then tell me I'm going to be exercising, right? And I know I don't expect anybody to go from laying in bed much of the day or being incredibly limited in functionality to running a marathon. But if you set very, very small goals, there is always room to get back to life, to kind of broaden your life. So the problem is many people, when they are setting a goal, set it completely broadly. It's that New Year's resolution phenomenon. I'm going to be healthier. I'm going to do so much better. I'm going to be a better person. That's all well and good. It sounds nice, but it means nothing because it's not specific. There's no accountability. There's no way of measuring it, and it's not realistic, right? So when you set goals for yourself, you want to think, okay, what area of life am I missing the most? What have I stopped doing because of my pain? Let's say, just for kind of ease, it's exercise, right? If you are basically in bed most of the time, then what you want to do is set something that's completely realistic. Maybe the first step is to just sit up in bed and stretch for a certain amount of time on a daily basis. And you move from that to standing up and doing light stretching standing. And then you move from that to doing kind of a walk around your house for about 2 minutes. And from there, you go to 5 minutes of walking. And from there, you go to walking to the mailbox and back, right? And so, really, when I say small steps, really small steps so you give yourself a chance to succeed at something. Because the other problem that happens with setting goals is sometimes we set the bar too high and we set ourselves up for failure. And if you set a goal that's impossible to achieve, then you're going to quit before you begin. And I have lots of patients that say, I just can't do it. It's not worth it, and give up before they've even started. Whereas if you set yourself up for success, the motivation to keep going really stays there. Um, Next is in terms of building our tools. And I put that picture up of a toolkit because I like to think of managing life with chronic pain, of thinking of it as having this huge toolkit. And maybe you pull 3 tools at once because in order to, let's say, do physical exercise, you have to do something to calm your nerves. So you might have to pull two of those tools at once. You might pull one tool for certain things and another tool for certain things. So I like to think of this as really building the toolkit. So education, setting goals, and now the next part is relaxation. Now, I do a lot of formal relaxation with my patients, but Janine and I were having this discussion of how, there's the little silver lining in this pandemic has been that so many things have become more accessible through these virtual modalities. And relaxation is one of those things. There have been so many forums for accessing relaxation, meditation, progressive muscle relaxation, all of these things that I'm listing here virtually. So I encourage you all to attempt to access the wealth of resources, whether it's from YouTube or it's from apps like Calm and Headspace. I'm sure you've seen commercials. I think they're on most of the networks. They have these commercials for those. They've made them very accessible. But the reason that relaxation can be incredibly important, specifically for chronic pain, is because you remember I had mentioned that acute pain is adaptive, chronic pain is not. So in chronic pain, not only is the pain itself not adaptive because it's not signaling any danger, right? We have this pain, but there's no damage necessarily, and there's nothing to necessarily do about it. But also, what happens when a person is chronically experiencing pain is they enter into this chronic fight or flight mode. We were built also as humans that if we were truly in danger, if our well being was threatened, there are certain changes that happen physiologically in our body to prepare ourselves to either run away or to fight whatever is coming at us. Back in the day, if a lion was running after me, in the caveman days, then and I got kicked into that fight or flight response, that would save my life. But if we are consistently kicked into this fight or flight mode and there's nothing attacking us, it's just that our pain is causing us to be in that, then what we've seen is it could actually be damaging. And what it can do is can create this chronic state of anxiety. It can actually create chronic muscle tensions in other parts of our bodies. Other things that happen in fight or flight mode, our hands, our circulation changes, and so the blood ends up pooling more around the vital organs, and the veins that go to our extremities end up constricting, so our hands and feet might feel cold. A lot of patients who have chronic pain have cold feet, cold hands. Blood pressure changes can happen. So it can not only affect our psyche, but it could affect our physical well-being too. If blood pressure is chronically high, we know that that could lead to heart disease. So we want to induce what's called the relaxation response, which calms our nervous system and releases that muscle tension, dilates our blood vessels, gets the blood flowing back to the extremities, helps get the blood pressure back to normal. What does that look like? It can look a whole bunch of ways. Sometimes relaxation can be as simple as breathing with intention or mindfully. Breathing while instead of doing a million other things, of course, we're all breathing all the time, but breathing and really noticing what it feels like to breathe. It can be muscle relaxation where we start at the top of our heads and go all the way down to our extremities, our fingers and our toes, tensing and releasing the muscles so we can really feel what it feels like to be fully physically relaxed. Autogenic training involves using some imagery with hot and cold, which can be incredibly helpful for pain. So you might imagine cooling imagery or warming imagery, depending on what feels better for your pain. Visual or guided imagery can be a couple of different things. So for some people, the imagery might take on almost like a distraction form. And I use this picture of this kind of beautiful scene. Sometimes people like just envisioning themselves an incredibly serene, beautiful scene. And in doing that, it relaxes them and might not change the experience of the pain, but by relaxing them gives them a greater ability to cope with their pain and improves their emotional state. We also sometimes use imagery to delve into the pain as opposed to distract away. So an example of that would be, I might have a patient who has neuropathic pain, which sometimes people can describe as burning, fiery-like pain. And so I would have a person close their eyes and delve into the pain, really almost like they had a camera in their mind, delve into their pain, notice what the experience is, come up with an image that depicts their pain. So for that person with the neuropathic pain, I had one patient who would constantly say, it's like this raging fire burning in my foot. And the flames are out of control, bright red, flaming, there's smoke going everywhere. So I have them hold that image, and then you gradually try to transform that image in a subtle way or in a major way. So this person would imagine a very thick wool blanket. Everything okay? Did somebody want to ask something or say something? I just saw somebody go off of mute, I think.
That's okay. I took care
Oh,
of it, Madeline.
okay, great. So that person imagines a very heavy wool blanket going on top of those flames, putting the flames out, and then kind of imagining that simmering effect. Now, is the pain gone? Did the person say they have no pain? No. But what is amazing is for a lot of people, using their minds to shift that image creates a different experience of the pain that can create a little bit of relief. So if that burning and fiery image shifts to kind of a smoking, simmering image, it might result in the shift in the pain sensation. The other thing I wanted to just give a little bit of a description of, and I could take you guys through a very brief exercise, is mindfulness, because I know that there's been a lot out there about what mindfulness is, and it's kind of like a buzzword right now. And I always say, for me, mindfulness kind of bears down to observing an experience in the here and now with curiosity rather than judgment. And it also is about kind of allowing for an experience as opposed to reacting to an experience. And so a lot of times people think that mindfulness is about seeing the beauty in something or going outside and noticing how wonderful everything is. And now, if you go outside and something looks beautiful, and that's what the experience is in that moment, then that's being mindful. But sometimes being mindful is not just about seeing beauty. Sometimes mindfulness is just experiencing whatever it is that you're experiencing, even if it's unpleasant, without that judgment. And here's where it can come in to be incredibly effective for pain. So one way that we use mindfulness is we might have patients become mindful of a specific process. So we might teach people, and you can do this, be mindful of, let's say, breathing, which is what I'll do with you, or eating, something that you do ordinarily, showering, washing your hands. And by being present in that moment, being mindful, being aware of what it feels like to do something, really attending to that, as opposed to what we typically do, which is multitask, right? We wash our hands while we're talking on the phone, while we're thinking about something else, or eating especially. We're very good at eating and watching TV, eating and talking, eating and thinking about what we have to do for the rest of the day, right? So doing an activity with really attending to it can feel very unique, especially in the current times where there's so many stressors. So sometimes being mindful of an activity, a specific activity, can be helpful in managing pain because it kind of pulls you out of yourself. It kind of quiets the noise that might be going on. A lot of times people will tell me, like that cartoon that I started with, that living with chronic pain, it's like constantly having this dialogue of like, oh my God, this hurts. Is this ever going to end? I'm not going to be able to do this. How am I going to get to my daughter's show if I can't even pick my head up off the pillow? And how am I going to, help my wife with this if I can't even move my leg? And right, it's this constant dialogue that is happening. And so sometimes by being mindful, we can quiet that noise and get grounded in just being present. And with that quieting of the noise, again, it doesn't resolve the pain, but it can ease the intensity of it. I'm going to take you all through a brief breathing with mindfulness just so you can experience what this feels like. So if you will all just take a moment, whatever you're doing, wherever you're sitting, and if you feel comfortable to, you can close your eyes and just allow some of the thoughts, noises, distractions that might be pulling your attention, let them all just fade to the background. If anything pulls your attention or distracts you, know that that's completely normal and it's completely okay. Just simply observe the distraction and then bring your mind back to your breathing. Allow yourself to get comfortable in your seat. If you're standing, to just get comfortable where you are. And kind of allow your breathing to take its natural form. Not trying to breathe any particular way, just letting yourself breathe naturally. As you breathe, take a moment to notice what it feels like as you pull the air in through your mouth or through your nostrils. Noticing if it requires some effort or if it feels effortless. not judging, just observing. Notice what it feels like as the air travels down through your throat and eventually fills your lungs. And now notice the reverse pathway as your lungs empty out. The air comes back out through your mouth or your nostrils. Again, noticing what it feels like in the different parts of your body. Take a moment to observe any sounds of your breathing, perhaps a silence or a subtle whispering of the breath. Might even hear your own heart beating. Remaining curious, what does this feel like? What does this sound like? Take a moment to observe the way that your chest expands and contracts with each breath. Perhaps feeling your shoulders gently rise and fall. Noticing the way your abdomen moves with each breath. You can also notice the stillness of the lower half of your body. Not judging, just observing. Take a moment to even observe where your mind is at as you breathe. Perhaps it's remained fixed on your breathing, or perhaps it's wandered a bit. Knowing there's no right or wrong here. Just allow for the breath. Notice your own rhythm. And now you can become more aware of my voice, of the chair beneath you, of the screen in front of you. You can open your eyes and just take a moment to notice, perhaps if you have not done any mindfulness, how different it may have felt to really attend to your breathing in that way. Also, take a moment to notice if while you were attending to your breathing in this mindful way, if pain, thoughts, stresses, mental to-do lists, if they were pulling you. Again, if they were, that's okay. You might notice that they weren't, which is also okay. So thank you for those of you who engaged in the exercise. This is one of the ways that we use mindfulness, being mindful of an activity outside of our pain. But I will also say that as people become more and more comfortable with mindfulness, one of the most helpful uses of mindfulness is to actually learn to be mindful of the pain. So often, we always say pain and suffering are not the exact same, right? You can be in pain and not suffer to the same extent. But one of the things that creates a tremendous amount of suffering is this endless fight against the pain. I got to get rid of it. I got to get rid of it. I have to find something. I have to find a way. I can't live like this, right? If you can learn to kind of coexist with your pain, which is not an easy thing, but if you can learn to be mindful of it, and not always, even if it's just at moments, then it can be incredibly empowering and it can really reduce that suffering. An example I will have, sometimes a patient will come into me while they're in the midst of kind of a pain flare or pain attack. And often I think what they think I'm going to do is distract them away from their pain. And sometimes I do. But sometimes what I'll do is I'll say, tell me about it. Describe to me every single part of your pain. And in doing so, in just staying in that place of being curious about it and describing the experience as opposed to judging it, right? I feel it here. I notice that it does this when I do this. It's pulsing. It's pounding. I can feel it here but not here. When I feel it in this way, it also leads to some nausea. When they stay in this place of just observing and not fighting against it, then sometimes inadvertently they end up feeling a little more empowered, and then the pain has less of a hold and it becomes a little easier to deal with. So that's also often the ultimate goal. If you've ever seen one of those finger traps, where they're usually made of straw, and it's like this little toy. I remember I used to have them as a kid, and if you put your fingers in it simultaneously and you pull, you're stuck. That's why it's called the finger trap. And what happens is, instinctively, most people, what they do when they're in this finger trap is pull harder and harder and harder. The harder you pull, the more stuck you get. And that's what it's like living with pain. Sometimes the harder you fight against it, the more stuck you get. Sometimes if you kind of give way to it, you give in, you kind of join the pain a little bit, you acknowledge, accept, not feel happy about, but you allow for the pain, that's sometimes when it just eases up a bit. So cognitive behavioral therapy and kind of shifting the way we think is another strategy. And if for anybody who's going to see a therapist to deal with their pain, this is going to be the bulk of the work they do. But these are things that you can also do on your own. And there are many apps that are available to now even help you doing some of this on your own. And what cognitive behavioral therapy, the concept that kind of is the foundation for this, is that our thoughts, our behaviors, and our emotions are all interrelated. So that if we can tweak one of them, in turn, we can shift the experience of the other. And what we often target is the thoughts. So that if we look at the way a person is thinking about their pain and we can make some subtle adjustments to how they think about it, what we often find is they can end up having a very different experience of the pain. If I have two people in pain and one person is thinking, I'm never going to be able to get through this. I'm never going to be able to live the life that I thought I was going to live. Nobody's going to understand me. And then I have another patient with the same pain, but they think, this stinks. I wish I didn't have this pain. But I know that by nature, people are resilient. And I think that there's been a lot of difficult things that I've gotten through in the past. And I think I'll figure out ways to deal with this moving forward. Those people are going to have very, very different experiences. So we want to help people develop those thoughts that are going to help them adapt. And one of the ways that we do this, our thoughts happen incredibly automatically. I always say shifting thoughts, it's like if somebody told you you're speaking wrong or you're walking wrong. You know, it happens so automatically. Our thoughts are so automatic. They're very difficult to change, but it's possible. And the way that we change them is, one, we have to become aware of how we're thinking about things. When you feel helpless or hopeless in pain, you take that step back and you think to yourself, what is making me feel this way? What is the narrative driving this feeling? And what you might find are catastrophic thoughts. Assuming the worst is going to happen, assuming I'm never going to get better, anticipating the worst case scenario. It might be a magnification, right? It might be that the pain is bad, but you're saying this is going to kill me, which is kind of a magnifying thought. It might be an all or nothing thought. If I can't run, then I don't want to do anything at all. If pain has taken away my ability to work, then what's the point in living, right? This all or nothing mentality might be triggering some of the depression or angst or upset. Emotional reasoning is I think, therefore it is. So you really want to tune in, what is the narrative that's driving some of my struggle with the pain? And once you have a sense of what that narrative is, then you can challenge it in these ways. You can kind of ask yourself, what's the evidence to support this notion that I'll never be able to deal with it? If I was in front of a jury, would I win my case? right? You can also use the double standard method where you say, if a friend of mine came up to me and said, my life's not worth living if I can't run anymore, if I can't work anymore, would I let them get away with it? Probably not. So how can I shift the narrative? And so by challenging this narrative, you then give yourself the leeway to shift it. And in turn, as the model suggested right before the slide, if you shift your thoughts, then you can shift your experience. In strict behavior therapy, what we sometimes do, or in terms of the strategies that you guys can use, you look at, are there things that we could tweak in the behavior itself? So the previous slide was about shifting the thoughts. This is more about, are there behaviors that we can shift that might help us or change our experience? So a couple basic ones that you can think about for any of you that are living with pain. If you are taking medication as needed, as opposed to, at certain designated times on the clock, then you want to see if you can shift to more of that on the clock model. Because what ends up happening is, if you're in a model of, I only take it as needed, then sometimes inadvertently, and it's not that it's awful, but sometimes what it inadvertently does is it sends the message to your brain that I'm in pain, the only thing I could do is take that medication. There's nothing else I can do, right? And so it ends up kind of increasing your dependency on the medication, and it takes away any sense of internal resources that you might have and any incentive you might have to kind of develop your coping mechanisms. Whereas if you take medication at when you wake up and then at bedtime, then there's less of an association of relief with just the medication, and you can develop a greater sense of, oh, there's things that I can do to help myself. You also want to notice if any of you have spouses, children, loved ones with pain, and you're listening to this talk because of wondering what you might be able to do to help them. One of the things that can sometimes inadvertently reinforce pain behavior, if a person is in pain, of course, we want them to let us know and we want to help them. But sometimes behaviors can be kind of habit forming. And sometimes if a person is only getting a lot of positive attention and reinforcement when they seem to be in pain, it might encourage them to keep kind of using those pain behaviors and decreasing their motivation to engage in well behaviors. So they might be complaining way more often, they might be far more needy, far more dependent. Whereas if you give just as much attention to when they, let's say, try to do a goal, try to achieve one of these goals, or use one of these strategies that we've talked about, and you really support them and encourage them, then it might help motivate that behavior more often. And then pacing is something that is crucial for all people with chronic pain, and it's essentially learning to do things in a gradual way where you balance an awareness of your body and awareness of your pain with also pushing yourself ever so slightly. And so going back to that example, let's say of goal setting, if a person wants to start being more active in walking, let's say, if the person had not been active at all, we don't want that person walking for 30 minutes, which a lot of people will do. If they haven't been active and the doctor convinces them, okay, it's time to exercise, they'll get up the next day and they'll exercise for 30 minutes. That's the worst thing you could do. Instead, what you do is you think, okay, what's typical? When do I typically start experiencing pain? If typically you start experiencing pain after 5 minutes of walking, what I usually say is cut it in half. Walk for 2 minutes, take a break, and then walk for 2 minutes, take a break, right? And set a goal of, let's say, 10 minutes, but breaks after 2 minutes. So you never let yourself get up to that point of excruciating pain. You're kind of really listening to your body. Now, with that said, what you do is you gradually increase the amount of time that you're active for, keeping with the breaks, but you're going to build endurance in this way. Whereas for people who push themselves without listening to their body, they end up into that push crash cycle where they push, then they crash and burn, then their body pays for it, and they kind of say to themselves, see, it wasn't worth it. I shouldn't have exercised at all. So pacing is an incredible tool that can help you with going back to that goal setting, achieving some of these goals that you set for yourself. Communication is incredibly important because we know, going back to that spiraling down slide, one of the things that can happen is social isolation and social withdrawal. A lot of times people with chronic pain feel alone and feel like people do not understand their experience. And it is not an experience that everyone understands, but there's many, many people who do live with chronic pain. But there are ways that you can communicate what unfortunately happens for a lot of people with their family members. If they're the one in pain and their family members don't understand it, or vice versa, is this kind of silent tension ends up building, and this silent resentment. The person who lives with pain ends up resenting the people who don't have the pain because they don't feel understood and heard and appreciated. And the people who don't have the pain end up feeling resentful because they don't know what it's like, and they might feel like, I don't know if it's real, I don't know what's happening, I don't know how to help them, I don't. And so when all else fails, it's always great to kind of go back to this um, assertive way of communicating where you focus on what your experience is. I feel this when you do X because of this, right? Um, I felt unheard when you kept pushing me to go to our friend's house, even though I was in pain, because it was too difficult for me to do, right? So you really focus on what you felt in certain situations. It's also important when you live with pain to learn how to say no, which for many people is a skill, right? It's hard sometimes to say no, but it is important to be able to say no so you don't develop that resentment. You don't end up doing things and then feeling resentful towards the people who you did. Terms of conveying your intentions, this is important when speaking to loved ones. It also can be incredibly important when going to doctors, because as we started out with, pain is so complex, and it could be sometimes a difficult experience communicating with a doctor about pain. I always encourage people, write down what your experiences are with the pain, write down the questions you have, bring them in. I haven't met one doctor who's unhappy when a person does that. Um, and active listening is just kind of a key communication strategy, which is when you want to feel heard, or you want to make sure that somebody else is feeling heard. For those of you who maybe have loved ones who have pain, you can reflect to them. You sound X about Y. Or, I'm hearing that you really are suffering right now. I am getting from you that you're really feeling invalidated. And so you reflect back to the person what you hear. This last piece is just in general, we know there's more and more research that says that these kind of key healthy living things, they help all conditions, including chronic pain. A lot of patients feel like, how is eating healthy going to help my pain? But, the more healthy you are, the more fit you are, the more reserves you have to cope with that pain. We know, same thing with exercise. It, of course, is going to be difficult for some people with certain conditions with pain, but the more you build up the rest of your body, the easier it is on whatever body part is hurting. For my patients with back pain, I always tell them, if you build a solid core, that is easing the tension on your back, right? We also know, by the way, that with foods, there are certain foods that are natural anti-inflammatories. And so you want to try to have a lot of those: spinach, cherries, certain things are very natural anti-inflammatory. On the flip side, there are some foods that we know can cause water retention and are going to exacerbate pain. So you really want to be aware of that. And sleep is one of those things. I would say 95% of my patients with chronic pain also have sleep issues. And it's natural that they go hand in hand. Sometimes the pain is so bad it's hard to fall asleep. For some people, their pain wakes them for their sleep. Or sometimes the pain causes such an inactive lifestyle that people are in bed all day and then they're up all night. They kind of have that reversal. And so sometimes by working on your sleep and getting your sleep into a better place, it in turn makes it easier to cope with the pain. So last slide, and then I'll allow for our questions, is just to kind of go back to this driver's seat metaphor. The greatest revolution of our time is the knowledge that human beings, by changing the inner attitudes of their minds, can transform the outer aspects of their lives. We might not be able to cure pain. We might not be able to get rid of that passenger, but if you can shift the way you think, if you can engage in things like relaxation, mindfulness, if you can educate yourself about your pain, if you could really pay attention to how you're communicating about your pain to your loved ones or how they communicate to you about the pain, if you can work on these other things like sleep, nutrition, exercise, then we could get that passenger in the trunk. We could duct tape that passenger so we don't hear them, and we could feel more in control of our lives and have a better quality of life. Thank you so much for listening. I hope I left enough time for questions. I saw that there looked like there was some things going on in the chat. So
Thank you so much, Dr. Gittleman. That was amazing.
absolutely. Sure.
We have a couple of questions in the
Yeah.
chat. I'm going to unmute. Actually, let's just see. Do you want to stop the screen share and that way I
Yep. Sure.
can? All right, great. And let's take a look. Okay, so we're going to unmute everybody. So I unmuted everybody. There were a couple of questions that I'm going to ask first that people had put down in the chat.
Sure.
Do you think you can elaborate on autogenic training? Is there a good schedule to follow? Heat then cold, cold then heat, for how long, how often?
So, it's very individual. So, I think that what I typically do when I'm working with a patient is I'll ask them, what have they experienced as more relieving? And if they haven't had the experience, what do they envision would be more relieving? So there are some patients who absolutely say, heat is best. A lot of my back pain patients like heating pads and heat. And so we'll use more heat imagery. On the flip side, there are some people who swear by more cold. So it's very individual, and I would go based on what your experience is of actually using hot and cold physically, and if not, what you envision would be. There are some people who like that kind of shift between hot and cold. And so I wish I had a better answer, but I think, for many of these things, it's a little bit of trial and error. And so you can try one version of the exercise, see how it feels, and then shift a little bit if you find, I think I noticed that I experienced the most benefit from this, so I'm going to spend a little bit longer on that. And that goes for any of the relaxation. A lot of times when I'm working with a patient, I'll introduce them to a number of different types of exercises. But once we find one that's effective, I'll say, listen, if it works, let's stick with it. But now you've built a toolkit so that if you want to try something else, you can.
Thank you.
Sure.
And let me just see. There was a question about elaborating on foods which increase inflammation.
Yeah, I used to have this list handy. I'm going to look for it, and if I find it, I can give it to you, Janine,
That would be great.
um, to possibly post with this. Um, Let me think offhand. So there are certain, like eggs is one of the ones that many people have like an inflammatory response to, kind of random. Dairy is also another food that a lot of people end up having an inflammatory response to, obviously individualized, but those are two that people are cautious about and might kind of try to eat less of. We know that there's certain things, so caffeine and so caffeine like chocolate and coffee and anything with caffeine, interestingly, can be a diuretic. So it might not create inflammation, but it can be triggering of pain. Headaches is one of those interesting things that has a very kind of complex relationship with caffeine. But for many other pain conditions, I will ask a person right off the bat how much caffeine they're having, because it does seem like caffeine beyond a certain amount can exacerbate many pain conditions. So we try to really reduce the amount of caffeine a person is having.
Okay, and I think we have a lot of books at the library actually on anti-inflammatory foods. So I put my email in the chat. So if anybody wants the list that Dr. Gittleman is going to send, just email me and I'll get it to you. And I'll also send you a list of available books on anti-inflammatory foods.
Thank you so
Okay.
much, Janine.
Yeah, no problem. Let me just see. What foods retain water? Is that part of the other question?
So salt is the biggest one, super salty foods. That's gonna cause the biggest water retention, which we know is gonna create a lot of problems for various pain conditions. So anything that's high in sodium, high in salt, we know that's going to cause problems for blood pressure, but it's also going to cause a lot of the water retention, which in turn can be problematic for pain.
Okay, and somebody had a question about, I don't actually see your question, but it says finding a pain management doctor and your insurance is impossible. New laws leave behind those with chronic pain, debilitating migraines, arthritis. We are shuffled doctor to doctor. Um, I don't know what your question is, but I'm assuming it's just, is that true that it's difficult to get?
So, unfortunately, I know that that's an experience that a lot of people are having. One of the things when I started off mentioning that kind of pendulum effect, um, I think one of the downsides of this pendulum swinging so far in this other extreme has been, a ton of legislation against prescribing, which has then in turn made a lot of doctors uncomfortable with treating patients with pain. And it's really created a problem in terms of access, um, and it's not as if they created a plan. So, okay, we're going to create a lot of legislation that's going to prevent a lot of doctors from prescribing, but we're going to create a whole alternate plan for these patients. That has not happened. And so I think your experience is one that many have had of feeling like they're kind of falling through the cracks and, like you said, shuffled from doctor to doctor. Sometimes the primary care doctor doesn't say, I'm not comfortable treating pain. Then they're referred to a pain management specialist who may or may not take their insurance. If they take the insurance, might say, well, you're on opioids and we're not taking any new patients who are on opiates. So it's really, if the question is this common? Unfortunately, it is. What my hope is, if the question is this going to change at any time? My hope is that, like most phenomenon where we see this pendulum swinging, there is going to be some backlash. We are going to get to a point where we realize there's so many patients who are not being served. And we're going to have the pendulum swing somewhere back to the middle where we, with proper protocols in place for assessing risk for things like opiate treatment, with bringing in new medications into the fold, with even maybe providing some funding for interdisciplinary treatment programs where there's many other options aside from just opiates, we'll be able to service more of these patients. I wish we were there. We're
Mm-hmm.
not there yet. Even in our department, we've been trying to kind of build more of an interdisciplinary program for patients like you. And there's a number of issues that come up, primarily, funding, things like that. Um, but I'm hopeful.
Mm.
I'm so
And
sorry that
I
I'm
have
sorry that that's
I
been your
have a
experience.
question. I am the person who asked that question.
Yes.
So what do we do in the meantime? We're treated like drug addicts at 71 years old. Um, and they're doing nothing for people with arthritis and migraines debilitating. For most of half my life, which was being controlled with a controlled substance, and now you can't get anybody. They take your money and then they say, oh, sorry, we don't do that. So what do we do in the meantime? Where do we
So,
go? Do
you
you give
know,
pain medications?
do I give any medications that we said?
Yeah, because I'm a Reiki master practitioner, level
Okay.
3. I can disassociate my pain at the dentist and a lot of places.
Yeah,
Certain things it's not working on. You
of
just don't.
course.
So
I do not prescribe. As a psychologist, I do not. I do work, within neurology. We do have two pain doctors here who I think are thoughtful, and I like to think of them as, not being very dismissive of patients with pain. So, I'm happy to give you that information of those doctors, although, to speak to the specifics of their practice, I don't know all the ins and out, but I do, from working with a lot of patients in conjunction with them, I think that they try to approach every patient individually and really are thoughtful in how to approach patients rather than dismissive. But, I think that some of these things, it sounds like you have a wealth of strategies that you use. We do know that a lot of the strategies that I've mentioned, are evidence-based, and maybe you've tried all of them and haven't had much success. If there's any that you haven't tried, I think it's absolutely worth trying some of them, including psychotherapy, which I know there's a whole other issue with accessing a psychologist, but that's always something I recommend. Hypnosis, those kinds of modalities I think can be helpful. In terms of accessing a doctor who might be willing to treat, I wish I had the answer for you other than the physicians that I practice with who I trust. I think sometimes it's kind of about trialing the different ones, communicating as openly as possible, including communicating about this experience that you're having, feeling so dismissed, feeling underserved, feeling like you're falling through the cracks. I think my experience is that some physicians at least respond to that and are, it makes them aware of the gravity of the problem.
How do you provide your number to those colleagues of yours?
Sure. So I'm in the Cushing Neuroscience Center. So I could give you the main number.
Okay.
I don't know if that's something you want to put.
Yeah, everybody's
Jen, or-
asking for your business card
Oh.
in the chat. We're getting a lot of requests.
So you know what I can do? My business card has that main number on it, so I can. Trying to think if I could show it to you guys, but I could.
If you give me the main number, I can post that in the chat if you want.
Perfect. Okay. Yes. So it's 516-325-7000.
Thank you.
Absolutely.
Okay, guys, I
Good
put
luck.
that in the chat. Yeah.
Good luck.
Thank you.
Did anybody else have any other questions that I missed? We had a couple people comment that they wish insurance would cover massage and acupuncture. I agree, and meditation classes.
Oh, absolutely. The truth is, I wish that insurance would cover all the psychotherapy for this, right? I mean, we have some patients whose insurance covers this and a lot of patients who don't. The only other thing I would say to all of you, I think there was supposed to maybe be an Assemblywoman on the line who's kind of been the one who organized all of this. And, I think that it never hurts to express what your experience is to, those who have some political pull and have some ability to maybe change the situation, whether it be writing a letter or, pulling together a number of people who might be having a similar experience. Because I don't think that any of you are alone in struggling to manage this and struggling to access the services readily. I know in this talk, I try to make it about what are the things that you can do at home. And I think that it can be incredibly helpful. And yet I know that it can also be that much more helpful sometimes if you have somebody guiding you through this process.
And we do offer meditation classes at the library virtually, as well as chair yoga and some, seated strength classes. That might be a good start. So if anybody has any questions about that, I put my email in the chat. You can ask me. I will forward you the events list, and it's all free. And, a lot of our friends in the community are all doing it. So, start there. I know it's not massage and acupuncture, but, it's a start.
Yep, absolutely.
Okay. I think we're about out of time unless anybody has anything else urgent. Thank you so much. This was so helpful. I really feel blown away by it. So thank you so much for joining us today.
Well, thank you so much for inviting me, and thank you all for staying on so long. I tend to talk a lot, so thank you for listening the whole time.